Hello everyone, my name is Luigi Basso and it gives me great pleasure to introduce the December 2017 monthly topic of the European Society of Oculoproctology on pilonidal disease. I have prepared my own presentations and coordinated a number of scientific contributions on this subject from literally around the globe: USA, Australia, Italy, Israel, Sweden, etc. Indeed, pilonidal disease, albeit benign, is a common and invalidating condition which frequently affects young patients and involves their families for quite some time. Often these young patients, due to pilonidal disease, see a surgeon for the very first time in their lives. There is no universal agreement regarding the best treatment or prevention methods. Probably the multiplicity of surgical procedures, as usual, witnesses to the lack of one optimal treatment method clearly superior to the others. This pilonidal monthly topic will deal with basic science of pilonidal disease and with different ways of treating it, from conservative methods to specialized surgical procedures. I personally favor minimally invasive surgery, which I have been performing for the last 20 years since my days in Ireland. Therefore, the title of my own presentation is Pilonidal Disease, a plea for minimally invasive surgery. Less is better, with exceptions. Indeed, there are probably exceptions when flaps rather than minimally invasive surgery should be taken into account. Although the more one surgeon is familiar with the minimally invasive approach, the less he or she has to switch to more aggressive surgery. Classical surgical methods to treat pilonidal disease, open surgery and marsupialization without primary closure, and closed surgery with excision and primary closure, probably still have a role, although most pilonidal disease dedicated surgeons favor either minimally invasive surgery or flaps. As a matter of fact, traditional resective methods are still the most taught in medical schools and the most practiced worldwide, although sometimes they imply 2 or 3 months of post-operative painful dressings. Hopefully, over the next few years, a larger number of surgeons will develop a special and dedicated interest in pilonidal disease. It should also be kept in mind that only a truly dedicated pilonidal disease surgeon can tailor surgery to the individual patient and not the patient to surgery. Finally, I would like to dedicate the present monthly topic to 2 surgeons who have been of paramount importance in my professional and not only professional life. Dr. John Bascom, 1925 to 2013, from Eugene, Oregon, USA, whose teachings and research on pilonidal disease have always been my northern star, and Professor Arthur Tanner, 1948 to 2017, from Dublin, Ireland, Master of Surgery and of Medical Science. Thank you for your attention.